So macrolides are usually used to treat a number of common infections. So examples of macrolides, erythromycin, azithromycin, and clarithromycin. Of all the macrolides, erythromycin is usually acid sensitive. So what this means is that it is destabilized in the acid environment in the stomach. So it has to have an enteric coating to protect it from the gastric acid in the stomach. But however, it is absorbed in the duodenum. Goes through the small intestine and it's absorbed in the duodenum. And it is distributed to most of the tissues in the body, except the CSF. But generally, if you look at macrolides as a class, they can enter the CSF when the meninges are inflamed. So if the patient has meningitis, you can treat with macrolide as a class, with the exception of erythromycin. It is metabolized in the liver and is excreted in the bowel. So most of the drugs that are metabolized in the liver are excreted in the bowel because the bowel is one of the ways that the liver is able to excrete its metabolites. Okay, sit down. However, small amounts are excreted in the urine and it can cross the placenta and be excreted in the rest of the city. Why did you bring more time to the room? Oh, I'm really doing. Sit down, sit there. Okay. So the way they act is by inhibiting the RNA-dependent protein synthesis, similar to the way clindamycin also acts by disrupting the 50S ribosome. Go downstairs and go and eat. Ah! So there are lots of therapeutic uses of erythromycin. It mostly has a broad spectrum of activity, gram-positive, gram-negative bacteria. So you find a wide range of microorganisms, mycobacteria, that is tuberculosis, treponema in syphilis and yours, mycoplasma and chlamydia, which can cause pneumonias and can also cause non-gonococcal urethritis. Staph aureus is also sensitive to erythromycin. And then we also have Legionella pneumophilia, which causes pneumonia in hospitalized patients. So generally, the macrolides are used as an alternative to penicillin in patients who are allergic to penicillin, And so you realize that the spectrum of activity is similar. So a lot of gram-positive infections with group A beta hemolytic streptococci, strep pneumonia, minor staphylococcal infections. And then also to treat syphilis in patients who can't tolerate penicillin G, either because of their sensitivity or maybe they have an adverse reaction to penicillin. You can substitute that with erythromycin. When it comes to azithromycin, it has a broad spectrum of activity against mostly gram-positive respiratory infections. So Mycobacterium, H. influenzae, Staph aureus, Moraxella catarrhalis, and chlamydia. And then you also find that it's active against pneumococci and group C, F, and G streptococci. If we don't remember what these are, we have to go back and revise our microbiology. So the next member of the group, clarithromycin, is also another broad spectrum antibacterial. And if you look at the spectrum of activity, you have gram-positive aerobes like Staph aureus, Strep pneumonia, Strep pyogenes. Mommy, leave me alone. Then you can also use it in combination with antacids. And when you're treating duodenal ulcer, it's part of the triple therapy. So you have clarithromycin, you have an antacid, you have proton pump inhibitor. And probably when we do peptic ulcer disease, we'll look closely at these. So the commonest drug interaction that you find with the macrolides is that they can increase the theophylline levels in a patient who has who is on theophylline. And this can be dangerous because theophylline has a narrow therapeutic window. So the least thing, you tip into theophylline toxicity. So whenever you are giving any of the macrolides with theophylline, you have to exercise caution. Also, patients who are on carbamazepine, you would find that the concentration of carbamazepine is increased when they are being treated with clarithromycin. The usual adverse reactions, nausea, vomiting, diarrhea, but additionally, they have a rash, they can have drug fever, eosinophilia, that is increased levels of eosinophils on the full blood count, and then anaphylaxis, which can present with an asthma-like presentation. Okay, so we'll go to vancomycin. It's important to note that vancomycin is not an antibiotic that should be toyed with, because we are increasingly moving towards the era of antibiotic resistance. And so it should only be used when the culture and sensitivity tests confirm the need for it. So you shouldn't use vancomycin in empiric therapy. It's absorbed poorly from the GI, so it's mostly given by IV, but you can also give vancomycin orally to treat pseudomembranous colitis. And it is well distributed in the pleural, the pericardial space, synovial, and then ascitic fluids. So if you are looking at infections around these areas, vancomycin would be a good antibiotic to penetrate these areas. There is no evidence metabolism, so about 85% of the dose is excreted unchanged in the urine within 24 hours. And a small amount may be eliminated through the liver and the biliary tract. So how does vancomycin work? It works by inhibiting the bacterial cell wall. And once the bacterial cell wall is damaged, then the body's natural defenses can attack the bacteria. And mostly it is a gram-positive, it's an antibiotic that is active against gram-positive organisms. So you have the Staph aureus, the Staph epidermidis, Strep pyogenes, Enterococcus, and Streptococcus pneumonia. Usually you give it in patients who have very serious infections with MRSA, that is methicillin-resistant Staph. You don't like it again, put it up. Wow. Patients who have Clostridium difficile colitis, who maybe they cannot be given metronidazole for one reason or the other, or who don't respond to metronidazole, can be given oral vancomycin. And when vancomycin is given with an aminoglycoside like gentamicin, oh, mommy, I'm going to cane you. Leave the room. Sorry. Please give me a minute. Go away, go away. Come on, go away. I'm going to walk it. Go. Don't come back. Sorry about that. So we can give vancomycin with the aminoglycosides like gentamicin or amikacin when you are treating Enterococcus faecalis endocarditis. So a patient who has infective endocarditis who is allergic to penicillin, you can treat with vancomycin plus an aminoglycoside like gentamicin or amikacin. So when you give vancomycin, in addition to any of these medications, it can increase the risk of toxicity, especially toxicity to the kidneys and then the ear. So aminoglycosides, we know that they are ototoxic and they have renal toxicity. So when you give it in addition to vancomycin, you increase this risk. Other medications in this category are amphotericin B, bacitracin. Cisplatin is an anti-cancer medication. It's used for chemotherapy. Colistin and polymyxin B are both antifungal, in addition to amphotericin B. That's also an antifungal. So we have the common adverse reactions. But it's important to take notes of the full blood count changes, which are eosinophilia and neutrophilia. Then hearing loss. So if you have medications that cause ototoxicity, for example, aminoglycoside being given with vancomycin, then you have this risk. You remember I was saying that in patients with infective endocarditis, you can give vancomycin and an aminoglycoside. So you need to watch out for the hearing loss, which may be transient permanent. Another thing that can occur with vancomycin is severe hypotension when you give it rapidly. So vancomycin is not giving us a push. So you don't put the vancomycin in a syringe and just push it through the IV line. No, you have to give it as a drip. If you are giving dosage of up to 1 gram, it should be given over 1 hour. And if it's more than 1 gram, then it should be given over 1 hour. Is usually associated with a red rash all over, and this is called red man syndrome. So vancomycin is peculiar in this sense. So we look at carbapenems. So a prototype of carbapenems is Meropenem, and they are a class of beta-lactam antibacterial. The other members are ertapenem and imipenem cilastatin. And this imipenem cilastatin is a combination drug. They have the widest or the broadest spectrum of activity, and they are reserved, like vancomycin, they are reserved for very serious infections or life-threatening infections with gram-positive and gram-negative infections, especially healthcare-acquired infections. So hospital-acquired infections, or what we call nosocomial infections, you would typically use the carbapenems. So when you take imipenem, it is rapidly metabolized in the tubules of the kidney, and after parenteral administration, it is distributed widely to various parts of the body. It is excreted primarily in the kidney. Ertapenem is given IV, just as imipenem, but it is more protein bound, and it is metabolized by hydrolysis and excreted in the urine. It is also widely distributed after parenteral administration. Meropenem is also widely distributed after parenteral administration, and its distribution includes a CNS. So if you have very bad meningitis, you can go for Meropenem, and it is excreted unchanged in the urine. The mechanism of action, they are bactericidal, so they kill the bacteria, and they do this by inhibiting the bacterial cell wall synthesis. If you look at all of them, the imipenem has a broader spectrum of activity. It's effective against aerobic gram-positive species like Streptococcus, Staph aureus, Staph epidermidis, and then Enterobacter, Pseudomonas aeruginosa. If you remember, I was saying that these are hospital-acquired, life-threatening hospital-acquired infections, and Pseudomonas is key in this group. So it's commonly used in treatment of serious healthcare-associated infections, especially in immunocompromised patients, because they have very weak immune systems. So you need very strong antibiotics to clear the infection. Meropenem is indicated for the treatment of intra-abdominal infections, and then the management of bacterial meningitis. If you remember the distribution, Meropenem is typically distributed widely in the CNS. If you take ertapenem, it is used for intra-abdominal infections, skin infections, UTI, gynecologic infections. So a patient with very bad pelvic inflammatory disease can be treated with ertapenem. Then community-acquired pneumonia caused by a variety of either gram-positive, gram-negative, or anaerobic organisms. So drug interactions mainly has to do with taking them with an aminoglycoside and probenecid. So if you take probenecid with imipenem, it increases the serum level and it causes accumulation to toxic levels in the renal tubules. Then giving an aminoglycoside with the imipenem is synergistic. You remember what synergistic action of drugs are, or potentiation, work better than you would expect from the single drugs. So common adverse reactions, the usual nausea, vomiting, diarrhea, but take note of the hypersensitivity reaction and then the need to adjust the dosage in patients who have impaired renal function. There is another slide, the last one, the antibiotics. So let's finish with antibiotics today, and then we can move to antivirals, God willing, next week. And Nick, am I still the host, or multiple people can share?
No, I just transferred the host to you once you said you were going to share another slide.
Ah, okay.
Yeah.
Thank you.
So,
Okay, so this last slide, we are going to cover monobactams, fluoroquinolones, and sulfonamide. And the last one is nitrofurantoin. Okay. So the monobactams, as Theonum is the prototype, is actually the only one available. It's a synthetic antibiotic. It has a narrow spectrum of activity. So most of the antibiotics we looked at, vancomycin, meropenem, they have a broad spectrum of activity. When we talk about narrow spectrum of activity, it means that it targets very few microorganisms. So this includes a lot of gram-negative aerobic bacteria, sorry. So it is given by parenteral administration. It is rapidly and completely absorbed, widely distributed throughout the body, and it is partially metabolized and excreted in the urine as an unchanged drug. Its action is mainly bactericidal, means that it kills the bacteria, and this results from the inhibition of the bacterial cell wall synthesis. And what it does is that it binds to the penicillin binding protein of the cell wall and inhibits cell wall division, and this leads to breakdown of the cell wall. So mostly it's active against gram-negative aerobic organisms. So you have a lot of the Enterobacteriaceae. So E. coli, Enterobacter, Klebsiella, pneumonia, Klebsiella auxitoca, Proteus mirabilis, Serratia marcescens, H. influenzae, and Citrobacter. So most of these microorganisms cause urinary tract infection because they are enteric flora, found in fecal flora. So you have a lot of complicated and non-complicated UTI, septicemia, lower respiratory tract infections, skin and soft tissue infection, intra-abdominal infections, gynecological infections. It shouldn't be used alone as empiric therapy, especially in a patient who is suspected to have a gram-positive infection, because we know that it has a narrow spectrum of activity and it's mostly targeting gram-negative organisms. So it's important for us to take note of this when we are managing patients. So because it shouldn't be used alone, it's commonly used with either the aminoglycosides or cefotaxime, Fundaments, or peripheracillin. And if you give the Theonum with other inducers of beta-lactam production like cefotaxime and imipenem, it may inactivate the Theonum. So usually concomitant use is not active recommended. Sorry. So usually you can also give it with clavulanic acid, depending on what organism you are thinking of. So if they are gram-positive organisms, then you can add clavulanic acid, and then it has a good coverage. So usual adverse reactions: diarrhea, hypersensitivity reaction, nausea, vomiting, but take note of the transient ECG changes. And then also the transient increase in serum enzymes. So the fluoroquinolones. Please give me a minute. Let me take my charger. Okay. So fluoroquinolones are also synthetic antibiotics. And a lot of the time they are used to treat urinary tract infection, upper respiratory tract infection, pneumonia, gonorrhea. And they include ciprofloxacin. So cipro is the commonest that we are very familiar with, but there are other ones. Levofloxacin, I think the brand name is Talvanic. It's very expensive antibiotic. We also have moxifloxacin, norfloxacin, and ofloxacin. So mostly when they are given orally, they are well absorbed, and they are not protein bound. They are metabolized in the liver and excreted in the urine. So fluoroquinolones, what they do is that they interrupt DNA synthesis. So there's an enzyme called DNA gyrase, which is very important in replication of DNA. So the fluoroquinolones will inhibit this enzyme, and therefore they would disrupt the whole DNA synthesis mechanism. And so the bacteria cannot reproduce, because you need DNA synthesis for bacterial reproduction, and effectively this is what leads to the killing of the bacteria. So they are mostly used to treat urinary tract infections, but each drug has its own specific indication. So cipro is usually used to treat lower respiratory tract infection. So you can actually use cipro to treat pneumonia. It's also commonly used to treat infectious diarrhea, skin, bone, and joint infections. When it comes to levo, it is used for lower respiratory tract infections as well, skin infections, and then urinary tract infections. However, moxifloxacin is used for sinusitis and then pneumonia. Norfloxacin is used to treat UTIs and prostatitis, that's inflammation of the prostate. Ofloxacin is used to treat sexually transmitted diseases, typically gonorrhea, and then lower respiratory tract infections, skin structure infections, and prostatitis. They are well tolerated mostly, so you hardly find adverse reactions occurring, but sometimes you can have things like dizziness, nausea, vomiting, and then abdominal pain. The very serious side effects of the fluoroquinolones are photosensitivity. So you can have moderate to severe phototoxic reactions when the patient is exposed to direct or indirect sunlight, and also artificial ultraviolet light. So either with or without sunscreen. And this can even occur after stopping the fluoroquinolone therapy. You have a lot of drug interactions. The antacids, for example, decrease the absorption of fluoroquinolones. And then they're also capable of potentiating the effect of the xanthine derivatives like aminophylline and theophylline. Remember, the same thing occurred in patients who are taking the macrolides. They can also have the potentiation of the xanthines. And giving them the cipro or norfloxacin with probenecid would lead to decreased kidney elimination. And therefore, you have increased levels of the fluoroquinolone in the patients. They can also prolong the QT interval. And so the ECG changes could also occur. Sulfonamides. So these are the sulfur-containing drugs. Straight away, I'd say that these medications should be avoided in patients with G6PD. The commonest that we know is Septrin, also known as cotrimoxazole, which is a combination of sulfamethoxazole and trimethoprim. And then we have sulfadiazine, which is used in as SP in pregnant women. So most of the sulfonamides are absorbed well. They are metabolized in the liver. Here with sulfonamides, a very important thing to take note of is that it can lead to stone formation in the kidneys. And so whenever you are taking oral sulfonamides, you should take a lot of water. In fact, even taking the medication, you should take about 250 ml of water to push it down, and drink a lot of water throughout the therapy, about 2 to 3 liters per day, to prevent the effects of kidney stone formation. The sulfonamides are bacteriostatic drugs. What they do is they inhibit the folic acid production, which is involved in synthesis of bacteria. They are commonly used to treat UTIs. So Septrin was one of the earliest medications that was used in the treatment of UTI. But if the patient has recurrent or chronic UTI, then you may want to look for another medication. And so the choice of therapy should ideally be based on the bacterial susceptibility testing or the culture results. They are also used to treat infections by Toxoplasma gondii, and typically in HIV patients who are at risk of opportunistic infections by Toxoplasma, you would give them Septrin. You would also give them Septrin for the treatment of acute otitis media, pneumocystic carinae pneumonia in HIV patients, and also for acute exacerbations of chronic bronchitis. They generally have a wide spectrum of activity against both gram-positive and gram-negative organisms. It's very important to take note of the drug interaction. They increase the hypoglycemic effect of sulfonylurea. So this means that if the patient is diabetic and is taking something like Dionel, taking that in addition to the sulfonamide can lead to low blood glucose level. And this can actually lead to hypoglycemia in the patient. So it's very important to take note. And then also when you take it with the medications like methenamine, it can lead to formation of crystals in the urine. And then they can also increase the anticoagulant effect of coumarin anticoagulants. And when you're taking it with methotrexate, it can increase the risk of toxicity of the methotrexate, in addition to cyclosporin. Adverse reactions, usually the crystals. And so if you drink a lot of water, this is averted. Hypersensitivity is another one. And the patient can have serum sickness and also photosensitive reaction. And the last antibiotic is Nitrofurantoin. It's commonly associated with liver disease, so it's hardly used, but it's used to treat UTIs, and especially in patients who have an underlying problem, you use it for prophylaxis in the management of chronic UTI. So it is given orally, it's absorbed rapidly, and when you take it with food, it enhances its bioavailability. 20% of it is protein bound, 20-60%. It causes the placenta, it's present in breast milk, distributed in bile, metabolized by the liver, excreted in the urine. So nitrofurantoin is usually bacteriostatic. What this means is that it doesn't really kill the bacteria, and it decreases their numbers and makes them ineffective. And the mechanism of action is by inhibiting the formation of acetyl-CoA from pyruvic acid. If you remember Krebs cycle, glycolysis, you remember where acetyl-CoA is. So nitrofurantoin will inhibit the formation of acetyl-CoA, which would inhibit the energy production in the bacteria. And this is what would lead to their slowing down their growth, because the bacteria needs energy to carry out its metabolism. It is concentrated in the urine, so it's very good for the treatment of UTI. But you hardly treat systemic bacterial infections, so it shouldn't be, because it's not effective. So very few drug interactions, probenecid and sulfenpyrazone, will inhibit the excretion, and so it increases the possibility of toxicity. Then also antacids can decrease the rate of absorption, and if you give it with norfloxacin, it decreases their antibacterial activity. So a few adverse reactions: take note of the dark yellow or brown urine and the abdominal pain. The rest are usually the common things that we know. Then you have the chills, the fever, joint pain, anaphylaxis, and headaches. So are there any questions for me? Any questions? So effectively, we finished with antibiotics. So next week we'll do antivirals, and then we'll see where we go from there. Please, are there any questions? There's a lot to take in. So I'm hoping that if we get the opportunity to read, then we can ask our questions. Hopefully from next week, I'll be sending you the slides ahead of the lecture so that you can go through and then ask your questions. How are your practicals going?
It's going well, though.
Now we have bread.
My brain.
It's good.
When your practicals. Daniel.
From exams to practicals to work.
The practical square is like exam. Nah.
Oh, sir. Yes.
Question is assignment.
Sam. Go and read this. Go and read that. Stand it, yo. Go and read this.
Wow.
When you start practicing, you realize that you can nothing special. Akosia, sorry. Are there any questions?
No, any question?
No, madam.
Why not? I no doing. You want to come inside? Come inside. Naughty girl. Okay, many questions there near me for.
Yo.
Good night. Have a good night.
Bye.
Bye.
Yes, yo.